Jamie, for inviting me to come and speak here. It was a very clever talk, Arturo. Quite enjoyed that immensely. However, ladies and gentlemen, this is a surgical talk. It's quite simple. It's one of those roll your sleeves up, get your hands dirty kind of talk. Okay. So I deliberately gave this title to Sarah, and I'm not jesting when I say that. We're truly on the threshold of doing something dramatic when it comes to surgery and the way we're going to progress over the next few decades when it comes to robotic surgery. I'll show you some data on this. Now, I gave this talk last year and I had a mixed response from the audience. 50% said, "We loved your gory slides. We want more of that next time." 50% weren't so sure. So every time a gory slide pops up, I'll warn, okay? So you can just put your hand over your face and try and peek through. So that's going to be the outline. So we'll talk about general aspects of robotics for 5 minutes and look at some conventional uses, a couple of videos in there, talk about research that's going on with the help of Oracle within the Marsden and nationally in this country, and some other international collaborative work we've been doing in robotics. And we'll take some Q&As perhaps at the end. So this is truly a $1 billion market. The businessmen here, please take note. That's 2.4 billion. I apologize for that. That's 2.4 billion as of 2017. I looked up the figures when I came in, and 2018 it's gone up to 3.6, and the projected growth for robotic surgery in the world in 2023 is a $7.9 billion market. So clearly something dramatic is going on that has really been taken up by surgeons, by physicians, and the role is only set to increase. And if you look at the number of papers published on the topic, so if you plug in robotic surgery into our database for looking at publications, you can get about 18,000 hits, and you can see the numbers going up from 1993 up to 2017. It's just gone up in leaps and bounds. Clearly patients are accepting of it, surgeons accept it, clinicians accept it, and that's why we are where we are when it comes to robotic surgery as a growth market. So I'll show you some pictures of what we have in the theater now, and I'll show you some pictures of what we have coming up in the future and where Oracle might potentially play a role in it. Jamie. So that's the older version, which we have signed out of. So that's gone away to it's gone to heaven. This is XI. XI is a newer one, and which is used for most robotic procedures, both in head and neck and outside of head and neck. This has arms that are easier to dock, but the future really lies in this particular model called the single port, SP for single port. As opposed to having 3 or 4 bulky arms in here, the whole thing is integrated into the single arm, allowing us to use it even in patients with limited mouth opening who usually have this problem after cancer surgery or cancer radiation therapy, and is going to be the market leader very soon. And this can be used not just for head and neck surgery, can be used for prosthetic surgery, for abdominal surgery, for gynecologic surgery, and this is where we believe the future might lie when it comes to robotics. Not just this particular model, it's single port, as in other robotic platforms also aim to achieve. This is a natural orifice robot, so meant for transoral use and transanal use, the other natural orifice. But the expense of this robot is similar to the existing robotic system, so this really didn't catch on because it allows only 2 specialties to use the robot, whereas it doesn't allow any other surgical specialty to pick up and run with it. For that reason, it hasn't had a great play in the robotic surgical world. The future is quite exciting. So this is fascinating. This is a homegrown Cambridge Medical Robotics System, which has now completed phase 1 and phase 2 trials in gynecologic surgery. We've done some cadaver work in head and neck cancer surgery, and it's based in Cambridge, and clearly it's hit the market with a 1.9 billion IPO a little while ago. This is Google's version. So Google and Johnson & Johnson have collaborated. They've been releasing schematics for the last 5 years. Nothing more than that. It's completely top secret. But they aim to use AI, that is artificial intelligence, to drive the robotic platform so that every operation we do, the AI system learns from it and allows the surgeon to push boundaries or hold back based on whatever the AI allows you to learn. So that should be fascinating when it hits the market in the next few years or so. So we have no more information about Google and Johnson & Johnson's version of the robot. This is another single port model by Titan Medical. That is from Imperial College. This is the iSnake, a much smaller robotic platform specifically designed for ENT. Again, this is in a much earlier phase of work and hasn't been really released into any further clinical practice. We yet to do cadaver work on this, but we are in talks with the Imperial team. But unfortunately, the Imperial team have lost their professor to China. He's moved off. He left last month, and so we don't know what the future of that particular robotic platform is, but that's where we are with iSnake. So the market is really interesting because it goes from the sublime to the ridiculous. So this is the Russian robot. This is the Indo-Chinese collaboration of robotic surgery, and both of them use off-the-shelf platforms, off-the-shelf software to try and drive the robotic platforms. This one was released just this year, a robot with one single indication, one single purpose. It's used purely for hair transplantation. That's how big the market is. So it shows to grow that. It goes to show that when it comes to robotic surgery, the cost is coming down, the number of platforms are going up, and clearly it's here to stay in one way, shape, or form. When the Royal College of Surgeons, which is our parent body, looked at the future of surgery, they published a large document in November 2018. This document was published in consultation with several stakeholders across industry, across physicians, and across fund holders. And in that 150-page document, the word robot occurred 146 times. Just to underline the fact that we are where we are with robotics. They're here to stay, and they're going away nowhere. And when you look at the model, this is Everett Rogers. He's an American health economist who showed that when it comes to diffusion of innovation, we are somewhere here in the early adopters. We have so much more to go when it comes to robotics in surgery in general. So that's my introductory section. Let's focus on robotics and head and neck cancer alone and see where we are in this field. So that's what we use. That's the XI model. So when it comes to robotic surgery, we aim to do everything through the mouth itself. We try not to make big holes. That's our aim. So we try and get away with more for less. So this is the robot docked to the patient's mouth. The patient has, I have full permission from patients to use these pictures, by the way. So these are patients who are anesthetized. They have a retractor to open the mouth as wide as possible. We then insert a telescope in the midline and then two other energy devices to cut and do whatever needs to be done to the tumor or around the tumor. And the assistant sits at the head end and places two retractors, two suction devices inside. So it's almost like having four hands inside, similar to a surgeon and his assistant, like open surgery, but the whole thing being done through the mouth itself. So that's the aim of robotic surgery. So I have to warn you, I have a video coming up, so if you want to shut your eyes, please feel free to. I hope this plays. So this is a video of a patient who has a tonsil cancer. And this is what happens. We're sat at the console and we are moving those robotic arms, and the vision we get here is similar to this. It's a clear vision, it's three-dimensional vision. It's almost like I'm sitting inside the throat and I'm cutting around that tumor, doing whatever I need to do. So that's the cancer. You can see that we made some cuts there, and this is exactly what we used to do for tonsil cancer 15, 20 years ago when we split the jaw. So we're doing exactly the same surgery. The extent of surgery is the same. The amount of tissue taken away is the same, but the only difference is we do it from inside because we have better access to do whatever we need to do. The vision and the access is what transforms what we do to these patients, and that's because of technological advances in imaging, in the instrumentation, and in the software. So that's my trainee. We both sat and we both see exactly the same thing, and because we can break the operation into multiple modular steps, I can perhaps let him do steps 1, 2, and 6, and I'll pick up for 3, 4, 5 and go back to 8 again, because these are difficult steps. And because we see exactly the same thing, because we have the same controls, I can ping the controls to my trainee when the trainee needs to do a particular step of the operation, and take the controls back when it comes to a difficult step. So the ability to teach students and trainees, surgical trainees, is better, and the learning curve for an operation like this, for an advanced trainee, would be 10 to 12 cases. And we're done dusted. So my trainees, when they finish off, usually can do this procedure relatively comfortably, having seen me do a few, and then they do a few individually, and they crack on and deliver the goods. When the tonsil cancer is removed, that's what it looks like. It looks like a big hole, but it heals up in 6 weeks' time. And patient swallow, based on good data we've collected, is quite pleasing, and they do really well from that perspective. So I'll stop that video. And this is single port. So as I showed you, that's the older version. This one here. So we have 3 arms going inside, and you can see how clumsy and clunky it is. We do get arm clashes at times, but with this one, single port, it's just one port that is docked outside the mouth, about 10 centimeters outside the mouth, and it is then, and the robotic arms are deployed, and this is what you get. So you get 3 arms in there, no clashes, and our ability to use 3 arms from surgeon itself, do whatever needs to be done, and the vision's excellent, and without instrument clashes, it's a different ballgame. We road tested this in Berlin, and will be on the market second quarter of next year, if you're interested in that particular piece of information. So, moving on to research. So this bit is completely Oracle driven, and we are very grateful to Oracle for this. So the unknown primary is a diagnostic dilemma for us. It's a treatment dilemma for us, because patients come with cancer in the neck. We don't know where it's come from. We do all the scans, we do take some biopsies, we have no idea where the cancers come from. And in the past, all we could do was take some random biopsies at the back of the tongue, because the tongue is inaccessible for easy biopsy until the robot came along. So with robotic surgery, what we can do is we can do a thorough and comprehensive and a repeatable examination of the back of the tongue, and then send that away to pathology, who can then tell us where the cancer is. And that allows us to define treatment better, to stratify treatment better, and to offer the right treatment for the right patient. Otherwise, all we had was one blanket treatment for these patients. So now we're able to offer targeted therapy and the right treatment to the right patient with the ability of the robot to take away the back of the tongue lining. So usually the cancer resides in the back of the tongue, somewhere here, on both sides. And before the robot came along, we could not take away this lining comprehensively and send it away for pathological examination. We got millimeter-sized biopsies, but look at the size of the specimen sent away. This gives, so if a cancer is found, we then treat the cancer. If a cancer isn't found, it gives us greater certainty in saying that truly isn't a cancer on the inside. Perhaps we can keep an eye on these patients and treat just the neck alone. So that way we're able to stratify the treatment for these patients. And this work, and this is what we do. So so that's the back of the tongue, and when we take away, this is what we send away for pathological examination. We did a piece of work across the country initially, across Newcastle, London, and Oxford, and we showed that we pick up more cancers, 50% plus. From a running start, from standing still, we get 53% just by doing that particular procedure in the right patient group, and we showed that it's feasible in other centers as well. So, and we also did some innovative work using the specimen. Instead of doing just sections conventionally, we started sectioning them at a much more closer interval, at 500 micron intervals, and that showed a higher pickup rate. So we now are at a situation where we don't know what to do with this particular piece of information. So that's why we have, with the help of Oracle, we have the Moses multi-center piece of work set up. There's a poster outside. This piece of work is across the country from Newcastle all the way to the south coast, and we hope to generate expert consensus in terms of surgery, in terms of radiation for these patients, how to treat these patients after tongue-based mucosectomy, which is the name of the procedure. So that's where we are, and this is entirely funded. We're grateful to Moses for providing us with this support, and John Hardman is leading on this piece of work across the country, and we're at a stage where we just opened 2 centers as of today, and we hope to have 10 more centers coming online very soon. So in terms of trials, clearly gynecological surgery and urology surgery, they have had a head start, and they have had phase 3 randomized control trials published in very high impact journals that we aim for. Clearly there are 18,000 papers in lower impact journals, and we have had the first high impact journal publication just a couple of months ago using robotic surgery in head and neck cancer, and that's the way forward, and we are heading the right direction. So that completes the bit about unknown primary. So that's conventional uses and research. So my hobby horse is now using robotic surgery for recurrent cancer, and that's why I came moved to the Marsden from Newcastle to try and push the recurrent cancer issue. So let me show you one slide with data, and then a bit of gory stuff. I apologize. So we looked at the data in the literature, and we showed that previously it was thought that if the cancer recurs after treatment, then treatment is not really valid, it's not required, because patients do very badly. But that's not the case. We looked at the literature very comprehensively. We looked at 22 studies in the literature and found 1,000 plus patients in there, and we put the data together. For some reason, from pre-2000 to post-2000, patients, for whatever reason, could be HPV, could be better care, they are doing better. And that seems to be the case across the board. So that gave us some confidence in saying, yes, with recurrent cancer, let's offer them surgery, despite our previous thinking that these patients may not do as well. And then came along this nice paper, which actually is an analysis from 2 high-quality trials, all radiation therapy trials, high-quality randomized control trials, which showed that when patients who have recurrent disease are salvaged, which is surgery after the recurrence, we can avoid death. There's a decreased risk of death by 56% or so. So that clearly gave us the impetus to try and find something kinder, which is another Oracle aim, to find kinder treatments for patients with head and neck cancer. And these patients, once you've had radiation therapy, they can't receive any further radiation therapy, because that's a ceiling dose for radiation therapy. So these patients purely have surgery as a backup. Warning, a bit of a gory slide. But this slide is required to get the point across. That is conventional treatment for patients with recurrent cancer. We split the jaw. That's a lower jaw that's been split open. The cancer was there. We've taken the cancer away. Then we have to put a flap in there, and we have to put the whole thing back together. And this is another patient with exactly the same problem. And if we can get away, and the problem with splitting the jaw in patients with cancer is, in the long term, despite flap reconstruction, the jaw falls apart. You can see the plate there peeking out. It's a real problem. We see that in 25 to 30% of patients in the long term. And this is an expensive problem to sort out, because one patient's the cost to treat one ORN patient is 70 to 80,000 pounds. It's quite an expensive complication to have. So if we can somehow not split the jaw, that'd be great. It's a real bonus for us. And by not splitting the jaw, we also are avoiding disrupting all the muscles along the neck here, which means recovery is quicker, patients have a better swallow outcome as well. So that's what we're trying to do. So we designed a trial. That's a surgical framework for designing trials. We did that, and we went to the lab, and we defined new ways of doing it, because conventional robotic surgery does not allow treatment of recurrences. So we went to the lab, defined the anatomy from inside out to take out multi-site tumors, which is new. We pushed the boat out for that, and then we started doing it systematically. We put the data together, and that's our data so far. Since I moved, small numbers, but the data seems to be heading just in the right direction. So including my Marsden cohort, with that median follow-up, clearly it's early follow-up, but my longest follow-up goes up to 60 months. We're getting pretty decent control of the cancer with this minimally invasive, kinder approach that Oracle clearly supports as a way forward in the setting. For example, this is a patient with a cancer at the back of the throat. That's the voice box, and that is the back of the tongue. And the conventional treatment for this would be to take out the voice box and the tongue at the same time and put a big flap in. So the patient has no tongue, no voice box, and just have a swallowing passage rebuilt. But with the robot, in 35 minutes, that's what it is. That's a voice box. Job's done. We have preserved voice box. The patient's swallow is short, clearly, but at least they have a voice box that is functioning, and they're able to communicate. And the surgical procedure is quicker, and of course the recovery is quicker too for this particular patient. Similarly, a tumor on 2 sides, that's a tonsil in the back of the tongue. 55 minutes later, job done in recurrent cancer, compared to splitting the jaw and doing a big operation, which would take 12 hours, and that's a usual time frame for a big operation. And we also learned to reconstruct. with the robot. So previously we thought we couldn't reconstruct, but we've done some work, and we have possibly the largest series. We have the largest series in the country, possibly the largest in the world, in terms of reconstructing, putting things back together with skin flaps from elsewhere with the robot. So that's where we are. So we then went on to the last few slides. We went on to then look for data outside, and we did a systematic review. Again, John is seminal in this, and we put data together from other centers which seem to have published small numbers again, and that's the data. So we are able to replicate. So it's important in science to try and replicate information and studies and results from multiple centers. It's no good for just one center to do it, but it appears that our data is replicated across multiple centers, and these results hold good. So we're not happy with that. So we thought, let's go one step further, and instead of taking published data, let's ask people to provide us with ongoing data so we can update and do what's called an individual patient data meta-analysis. So we now set this up. We have 16 global centers now sending us data to the Marsden to try and resolve this issue on a comprehensive basis, to show that robotic surgery, the minimally invasive technique, works in recurrent cancer. And that work is going on. We have data coming in now. We have everything in place now, and we should be able to analyze and publish this in the middle of next year, just when the single port comes out. And finally, this is our next piece of work. So this is not our brainchild at all. This is a very clever biochemist in Imperial who decided that by analyzing the smoke that emanates when we cut tumors out, and we can do something called a mass spectrometry, and you can rapidly analyze the smoke and look at the fat signature in the smoke, and that gives us an idea whether we're cutting through tumor or not tumor. And we can also separate that into muscle, fat, gland, and lining, and so on and so forth. So we have validated that in the lab using snap frozen tumor specimens, and we're getting really high specificity and sensitivity for this particular technique. So this green dot is what the screen readout is. So if I'm cutting through normal tumor, I get a green dot, and the minute I cut through tumor, I'll get a red dot. And the real-time feedback is 0.2 seconds. So within 0.2 seconds, I'll know if I'm cutting through tumor or not tumor. So we're trying to now integrate that into the robot in the theater. So that will avoid us having to go back in the rare instance to get an additional margin, and gives us further confirmatory evidence that we are cutting the tumor out completely. So we have a PhD student identified for this, and we're looking for money to support the PhD students. So, in conclusion, seriously, Oracle has been immense in supporting head and neck cancer research. There is significant global expertise in robotic surgery, a lot of research in robotic surgery going on. I've shown you some data on this. There is a lot of improvement in technology. Transoral robotic surgery is here to stay, and Oracle is playing a major role in the evolution and the revolution of robotic surgery in head and neck cancer field. And because of the work we do, we have the kudos, and we have the ability to host a large European convention on robotic surgery in head and neck in November, and that is fully subscribed, and we're holding it at the Royal College over 2 days. And thank you very much for your support.